Good evening to everyone and welcome to today's session. Today we shall review celiac disease, which is one of the favorite topic of the examiner, Whipple's disease and tropical sprue, the drugs of abuse in pharmacology, and one more topic that would be tumor suppressor genes, which is going to be a very high yield area for the examiner. If you remember, we have reviewed previously oncogenes. So it is a continuity of what we have reviewed as oncogenes. Now, let's talk about the celiac disease. Celiac disease. So what is the other name for the celiac disease, doctor? Celiac sprue, or it is also called gluten sensitive enteropathy, is the other name which is being given. It's an immune mediated enteropathy is what we need to understand. So the food containing the gliadin, which is the protein which initiates the celiac disease, ultimately why gliadin should cause injury to the intestine? It is autoimmune mediated. So that's the reason it is called immune mediated enteropathy is what you have to basically remember. So we welcome our online students Harika, Ritu, Lakshmi, Pranita. Please tell the other students to log into the same online FMGE only. So, right. So it is a gluten which is contained in the cereals like the wheat, rye or barley in the genetically predisposed individuals is typical of celiac disease is what you have to basically remember. Now what is the culprit protein inside these wheat, rye or barley? One of the favorite questions of the examiner is, what foods are bad and what foods are good? Wheat, rye and barley are bad for the celiac disease. So they have a gliadin which is the central theme, which is the central culprit. The gliadin is the protein. So what is the pathophysiology? Once the gluten is digested by the luminal brush border enzymes into the amino acids and peptides like any other protein which we take in the food, the alpha gliadin peptide is basically resistant to the degradation. That is, it is not degraded by the alpha gliadin is a part of the gliadin taken through the gluten. The pancreatic, gastric secretions, none of them can't further degrade this alpha gliadin. Then these gliadin peptides will then induce the production of the interleukin 15. So tomorrow's exam, when the examiner asks this question, you need to be quite sure about which interleukin it is. Interleukin 15. Interleukin 15 triggers the activation of and the proliferation of the CD8 plus intraepithelial lymphocytes, and they will typically cause the induction of a natural killer cell marker called as NKG2D is the one which is ultimately expressed. So after that, what will happen? These lymphocytes typically are cytotoxic. They will kill the enterocytes. Very good, sir. If the NKG2D is expressed on the CD8 positive cytotoxic T cells, why they should injure the intestinal epithelial cells? Because on the intestinal epithelial cells we have the expression of a receptor called as MICA. This MICA is the receptor, is the one which binds with NKG2D. So summarize, gliadin will induce interleukin 15. Interleukin 15 will induce the lymphocytes which will express the NKG2D, that is the cytotoxic T lymphocytes. those cytotoxic T lymphocytes with NKG2D will bind with MICA, which is there on the intestinal epithelial cells, and that lead to the ultimate injury. So what is this MICA? Basically, MICA is one of the HLA class 1 protein which is expressed on the intestinal cells, is what we have to ultimately understand. So once this happens, there is a breach in the intestinal epithelium, and that breach, just a moment. That breach typically will lead to the entry of these gliadin proteins further into the tissues, and in the tissues we have what are called as tissue transglutaminases. This tissue transglutaminase will deamidate this gliadin protein peptide which made an entry. So the deamidated gliadin peptides will be interacting with HLA-DQ2 or HLA-DQ3 on the antigen processing cells, and that in turn will make the T cells to produce the cytokines, which will ultimately lead to all the destruction which you see in the intestine. Long story, right? So you have the gliadin. Now you can understand this illustration easily. You have the enterocytes, there is no breach. The gliadin will initiate the production of the IL-15, that in turn will stimulate cytotoxic T cells to express the required receptor to bind and cause damage to the intestinal epithelium. That will break the gliadin to get exposed to the transglutaminases, and that lead to deamidation of the gliadin, and the deamidated gliadin in turn will cause the HLA-DQ2 to express. The antigen presenting cells will then lead to the ultimate destruction of the intestine. That is the whole story. Now, doctor, lot of people eat wheat, rye. Why everyone who is exposed to the wheat and rye doesn't develop celiac sprue is an important question. It is only the people who are homing this HLA-DQ2 or DQ8 allele are the ones who are genetically predisposed to get the celiac disease, is what need to be remembered. Now, what are the important other associations which you need to remember about celiac disease? Type 1 diabetes, thyroiditis, Sjogren's, autism, depression, IgA nephropathy, so many other things are associated because they too have an autoimmune basis, is what you need to understand. Now, doctor, one of the favorite MCQs of the examiner, where will you take the biopsy if you want to detect the celiac disease? You must be very sure to answer in the tomorrow's exam. It is not ileum, it is not distal jejunum, it is the duodenum, and the proximal jejunum is the one which is typically associated with the, from there you will take the biopsy. Because they are the areas which are having the highest amount of exposure to the gluten, is what you have to ultimately understand, doctor. So now, let us say the intestine. What has happened to the intestine? These are the healthy villi. And in the celiac sprue, what has happened? There is a blunting of the villi, is a very, very classical feature. Now, doctor, can you depend on biopsy findings and say, yes, this guy is having celiac disease? Yes, they are diagnostic findings. Now, what are the histopathology of the celiac disease? Lot of intraepithelial CD8 positive T lymphocytes will be there. What is that finding called as? Intraepithelial lymphocytosis is a very classical feature. The intestinal crypts are there, no? They undergo hyperplasia. But the villi will undergo atrophy. This you need to be very sure. Villi don't undergo hypertrophy or crypts don't undergo atrophy. Crypts undergo hypertrophy, villi undergo atrophy. We need to be very clear. Then because of the loss of the villi, there is a development of malabsorption. That is how the celiac disease presents itself. In fact, it's a very difficult diagnosis, celiac disease, if you don't suspect. Because in a person, malabsorption will have hundreds of causes, unless out of that one of them is celiac sprue. To guess it, you need to take a proper history. Then in the lamina propria, one of the very classical findings is, in case of celiac sprue, plasma cells, mast cells, eosinophils. They are all increased in the numbers in the upper part of the lamina propria is a very, very important finding. So, doctor, based on the histopathology, once more we grade the celiac sprue. This is the normal with full villus structure. This is called infiltrative state. This is called hyperplastic state, partial atrophy and total atrophy. That's what we need to basically understand. Now you can see here, this is the biopsy of the intestine in a patient who is having an active disease. And after stopping the gluten, once more the villus structure has recovered. So most important part of the treatment of the celiac sprue is to prevent the diet which is containing the gliadin protein is what you have to basically remember. Now once more, this is a normal intestinal biopsy, and this is a guy in whom there is a blunting of the villi with the hyperplasia of the crypts. This is what we are saying, intraepithelial lymphocytosis is a very classical feature. You are able to see all those lymphocytes. Intraepithelial lymphocytosis is a classical feature. So villus atrophy, crypt hyperplasia, and the presence of just 1 minute, doctor. Life has become miserable with smartphones. Yeah. So villus atrophy, crypt hyperplasia, these are the important features. Now, doctor, what is the age group where you are basically expecting? 30 to 60 years is the common age group. I hope the voice is loud and clear for all our online students. If you have any issue with the voice, please punch into the chat window. Yeah. Anemia, chronic diarrhea, chronic fatigue. These are all the important predisposing factors. Then, why in women it is more common to find symptomatic form of celiac disease than that of the men? Because in the women, at every monthly menstrual bleeding, there is an increased demand for the iron absorption, which also occurs in duodenum. If there is any villus atrophy, then that iron absorption doesn't occur, which is expected at the time of menstruation. So that's the reason anemia will be much more clinically obvious in the case of the women. Hence, women will show clinically a greater presentation of the celiac disease. Now, if you look at the celiac disease, there are symptomatic patients, symptomatic celiac disease with mucosal lesions, and we are having silent celiac disease. The major people, lot of people will suffer. That's the reason celiac disease is considered to be a disease of iceberg phenomena. Just like lot of asymptomatic poliomyelitis cases will be there, only 1 or 2 will be symptomatic, which will be detected like that. Now, if you look at the pediatric celiac disease, what are the classical symptoms of pediatric celiac? Within 6 to 24 months of age group, after the introduction of the gluten in the diet, until 6 months, baby is taking the mother's milk, no issue. No problem in, even though there is a problem of celiac disease. So irritability, abdominal distension, chronic diarrhea, weight loss, muscle wasting, these are all the features which you see in the patients who are having a typical pediatric form of celiac disease. Whereas in the pediatric form you have a non-classical stage where it is more in the older people. Now what are the extra-intestinal manifestations of the celiac disease, which is one of the favorite MCQ of the examiner. They can present with arthritis. Sometimes they may end up with a neurologist because of the seizure disorder. And after stomatitis, iron deficiency anemia in women, and pubertal delay which can occur. Short stature can be a presenting problem in the case of the celiac disease. Now, one of the important cutaneous association with the celiac disease, dermatitis herpetiformis. Which part of the body it is, doctor? It is the exposed surfaces, like extensor surfaces on the upper limbs. Grouped vesicles are the very classical feature. In case of dermatitis herpetiformis, they are very itchy, they are very blistering in nature. That is how you describe dermatitis herpetiformis. And there is also increased incidence in the people with celiac disease for the lymphocytic gastritis, lymphocytic colitis, etc., etc. So what is the main treatment, doctor? The only treatment is gluten-free diet. But what are the long-term complications? Are we worried about any cancer risk? Yes, sir. Long-term anemia can occur, osteoporosis, because calcium absorption also get, protein and calcium absorption are affected. Female infertility it can lead to, and malignancy is definitely a risk factor, is what need to be remembered. Now, doctor, what are the most important way of evaluation of a patient who is having celiac disease? Serology. This is one of the favorite MCQ of the examiner. IgA antibodies to the tissue transglutaminases. Is the voice clear? It's coming as voice doubling up. Is it only a problem with Neha or others also? Please let me know. Please check, is the voice clear enough? Okay. IgA antibodies to the tissue transglutaminase is one of the very, very sensitive tests. Then IgA and IgG antibodies to the deaminated gliadin is there, no? They are also very sensitive. Then these are the sensitive. That means if they are there, that doesn't mean that there is celiac disease, but in the very early stages of celiac disease only you can find them. But what is most specific in case of celiac disease? Anti-endomysial antibodies, one of the favorite MCQ of the examiner, is very, very highly specific for the celiac disease, is what need to be remembered. In few people there can be IgA deficiency genetically. In such people, if you want to depend on IgA antibodies against the tissue transglutaminase, it becomes difficult. So that is the reason in such people, the IgG antibodies to the tissue transglutaminase and also towards the deaminated gliadin are the better things, is what we have to fundamentally appreciate. Now, how about HLA DQ2 and DQ8? We need to remember, they are very important for their negative predictive value. Negative predictive value. That is, if they are not there, it is unlikely that it is celiac disease. You are suspecting, doctor, clinically, but you didn't find the presence of HLA DQ2, DQ8. Then it is unlikely that they are having celiac disease. But their presence does not prove anything. So negative predictive accuracy is more important for them rather than their positive predictive value. Then The people who are having celiac disease, they have higher than normal rate of malignancy is what you have to basically remember. Then what kind of malignancy is very common? One of the favorite MCQs. Enteropathy associated T-cell lymphomas. You remember we discussed it in the topic of lymphomas about almost 2 weeks back. Past 2 weeks we are swimming in the pond of pathology only. But pathology is worth it. Once more, in general medicine there is no need of reviewing celiac disease in gastroenterology, right? If you read very well in pathology. Enteropathy associated T-cell lymphoma is very common. Similarly, adenocarcinoma of the small intestine is also very frequent in the people who are having the celiac disease is what you need to remember. And in which subset of population do you expect cancer, doctor? Generally a Whipple's disease guy, if you stop him on the foods which are containing gliadin, then he is supposed to get a clinical response. But if the person's weight loss, abdominal pain, diarrhea, they are all continuing in spite of making him gluten free, then you need to suspect the possibility of underlying malignancy in the case of the Whipple's disease is what you have to basically remember. So what is the main treatment? Avoid wheat, rye and barley, and the patient should know what foods possibly can contain gluten. Breads, cakes, cereals, cookies, pastas, noodles, pastries, rolls. Of course, if you are an Italian guy, or probably if your fiancé is Italian, then very difficult situation it would be. So next comes the tropical sprue, one of the important area for the examiner. Tropical sprue is also a malabsorption condition, but you need to know difference between tropical sprue and celiac sprue. They are different from each other. Total villous atrophy, if you take, which is a feature of celiac disease, is uncommon in tropical sprue. Celiac sprue involves more often proximal part of the jejunum and duodenum, but distal part of the small bowel is the one which is involved in the tropical sprue, like ileum. Where will vitamin B12 get absorbed? Ileum. So vitamin B12 deficiency anemia and megaloblastic anemia are more common in tropical sprue, whereas iron deficiency anemia is more common in celiac sprue. These are those fine things. Ultimate nirvana of exam means even this kind of questions also you are able to answer if examiner asks you in the tomorrow's exam, means you reached that altar of getting wedded with postgraduate seat. Then why tropical sprue? It is the aerobic enteric bacteria whose overgrowth is the underlying cause is what need to be remembered. And how do you treat? Since it is considered to be an overgrowth state of the bacteria, try to treat them with broad spectrum antibiotics is considered to be a very, very important part of the management is what need to be remembered.